Continuing with our tradition of organizing academic programs and conferences, here we are with a very special talk today by Dr. Amit Sharma. Dr. Sharma did his graduation from the Rohtak Medical College and he did his DNB in orthopedics and then moved on to England where he did his MRCS and FRCS in orthopedics. Dr. Sharma is presently at the Luton and Dunstable Hospital, his areas of specialization being trauma and lower limb arthroplasty. Sir, we are indeed honoured to have you here. And may I now invite the Honourable Vice Chancellor, Professor Dr. Shamlal Singla, to kindly come and welcome our Honourable Speaker and the august gathering.
Today we have with us Dr. Amit Sharma, who is a renowned orthopedic surgeon in the UK and he is master of arthroplasties. I was just talking to him that we don't have the best orthopedic surgeons in arthroplasties in this institute. We have only some. He expected there must be some 20-30 top surgeons here. We have hardly 3-4 only. So the number is going to be small as far as your specialty is concerned. But we have a lot of students from physiotherapy department. I think whatever plasties you do, kindly don't mind my words because I'm very poor in this. Whatever you do in these specialties and these problems, ultimately the job is left to the backbenchers sitting there. They are real people, I think, who look after what you do later on. And that's why we called all them here so that this lecture is useful to them as well. With these words, I welcome you here on behalf of the university and we really appreciate you have taken the effort to come to us. Thank you very much.
Actually, I have been a student of your Vice Chancellor. He's been my teacher since I was in MBBS. And it was such a pleasure to be invited by him for a lecture. It was very, very nice and I'm so pleased that there is such a big audience. It doesn't matter which part of medicine you are from because we all tend to work as a team. And in my team where I work in Luton Dunstable Hospital. I think the most important people are the people who take over after I've done my butchery with a knife. So everything that happens afterwards. That's the philosophy that we tend to follow there, that we are just trained to do one thing and the treatment is not completed till the end, till the patient actually walks out with a smile. Now what I was going to talk about is I do a lot of arthroplasties, especially the knee arthroplasties. My hospital caters to a very large population, almost of 500,000. And a large part of our population is aging as the phenomena is in the West, and most of those guys need dealing with their knee problems and hip problems. So besides trauma, these are my main customers and I operate a lot on knees especially. My interest developed with I was always interested in orthopedics because of the gadgets it involves. And one of the very new thing that has started in, actually when I joined orthopedics in UK, the new thing that had come in was computer navigation. And so I've dedicated part of my career to developing that and I'm going to talk about that mainly. So I'll keep it basic. I don't want to confuse or try to give you any odd things, but I'm very happy to take in questions in between also and at the end also of the lecture. Just feel free to ask me anything. So, as we all know that when we do a total knee replacement, it's usually to correct a deformity that occurs after osteoarthritis, or very rarely we do it for increasing the stability and motion. So whenever I talk to a patient, even here when I come, I'm approached by so many patients saying that they have got knee pain. What should they do? They've tried everything. I'm sure you as physician in any specialty, even general surgery, would come across patients, your relatives asking you, and there is a big sort of barrier. I grew up with the same barrier when I was in India, that having a replacement surgery is big deal. and that you might just end up losing your leg or something. So I remember till I did my post-graduation here, I was advising people not to have surgeries and just carry on as long as they want to. But I think everything like that has changed. Now it's like IOLs, ophthalmic surgeries. We offer knee surgery to almost anyone who asks for it. The question we ask them is, do you think you can live with the pain you have in your knee? And if they respond that yes, then we say, okay, carry on. When you feel that you are ready for a surgery, which might have few complications, come back to us and we'll do it. So we don't decide for the surgery. We leave the decision with the patient, that you are going to suffer with the consequences of the surgery if it goes wrong. So you decide. We only have to do the butchery. I keep saying butchery, it's just, we do a very nice surgery there. So this is what I was talking about. This simple computer is my friend most of the times when I'm doing surgery. And as you can see there, this is, what we do is we put some probes on the knee joints, and we have a receptor there and the computer screen. There's a sterile thing that we put on the top there so that between surgery, if I feel like, I can move it around. This has actually revolutionized the knee surgery quite a lot. I'll take you through what we used to do and how this has changed, and it has quickened my results. It's made it almost perfect. As you know, machines are all supposed to be better than us, and this machine has really proven that it's best for doing any kind of knee surgery. So that's another navigation system you look at. So almost using the same principle. That's the cockpit of an aeroplane. We're using the same principle to make and decide where to cut the bones and put the implants. That's the picture we get. Now, whenever we are doing knee replacement, we come across many kind of obstacles. We are looking at odd kind of knees which are bent in either directions. I do come across these kind of knees which are going on the sideways. I'm sure you must have seen your old granny walking with varus and valgus deformities. This is very common, and all of them, almost invariably all of them, should have a knee replacement. So next time you see your grandmothers or fathers, just advise them to go to a knee surgeon and get them replaced. So our aim is to, I'm sure all of you would have undergone training in how to get the axis of balance through the knee. So our main aim always is to restore a straight line to the center of the hip going down to the center of the ankle. That's the principle we use, basic, that helps in navigation surgeries in knee joints. That's one thing we are restoring, that is not going to the sides. The next challenge is, after we have cut the knee joint, we don't want to make it low than where it should be. God gave us a knee joint in a perfect position, and we can't change it from there. We can't make it go up and down. The thing that causes problem if we do that is the knee cap. You could have patella, baja or alta if we alter that, and that leads to very bad patient outcomes. So that challenge also is answered by the knee navigation systems that we use. This is an example of how we can lower the joint line after we have cut a knee joint and replace it with man-made things. So we all have grown up thinking that knee joint, as medical professionals, that knee joint only moves in one direction. Well, that's not true. So the challenge doesn't end there, that we just cut it and put a hinge there. So knee moves in other directions that we don't imagine. It does slide a bit, it rolls, and it even has got sideway movements, which we were not taught in the anatomy initially. And those movements are key to success in a good knee replacement. When I was coming up, we were using incline to climb up, and Dr. Shan Singh was asking me, is that good for our knee? And we were discussing exactly this, sir. The knee actually undergoes quite a lot of stress. It's like 7 times the body weight stress goes on the knee or in the patella itself when we are climbing up. And in fact, in the next slide I'll show you, climbing down, it's even worse. The joint reaction force, as they call, is going straight into the kneecap. But that doesn't mean, as I was explaining, we stop climbing stairs and giving. Our aim is to keep working, keep doing, leading our normal life. And when the stage comes that we can't control it, we're struggling with doing our day-to-day activity. That's when you need to see the orthopedic surgeon for a replacement surgery. So what I was explaining here is that keeping this in mind, we also have to decide, your grannies and the old people, why they can't climb stairs is because of the stiffness that develops. And one of the reasons why we advise early knee replacement is the more you leave the knee without a replacement, you end up stiffening not just the muscles and tissues there, everything around the joint becomes quite rigid. So even the outcome after a knee replacement surgery becomes worse. So one of the reasons for an early joint replacement is that. So as you can see, for coming down the stairs, you need to bend your knee more by 20 degrees than going up the stairs, which was news to me when I first read it a few years back. That's the start of our knee joint, the patella. That causes most of the pain in my patients. Now, this simple activity has increased the patellofemoral joint reaction force by 7 times. Can you imagine 7 times the weight of this person is now passing through his knee joint? So that's another challenge we have to face when we do a knee replacement. And this is what we do in knee replacement surgery. We cut off the bone ends, and replace them with these metal and these plastic things. They come in various forms. There must be around a couple of thousand different varieties of knees in the world. This is one example I'm just showing you here. This is what it looks like. It's a 3D reconstruction after we have put the femoral part of the knee replacement. Now the femoral components, as I was saying, how we overcome all those various challenges. The knee doesn't just hinge around one point, it rotates, it slides. So we got these new designs that are coming up where the radius of rotation changes after every few degrees of movement. So they are very specialized and very modern kind of implants which are coming into force now. That's the tibial component. The other side of the knee, we are putting the metal plug in there. We also replace the kneecap. There are various kind of knee. There is not just various types of knees. There are various kinds of knee replacements. There are some challenges whenever we do knee replacements. Especially I showed you the polythene. That is our biggest enemy whenever we do a knee replacement. Because it's soft, the polythene particles, they very small particles come out, they cause loosening. Those small particles of polythene are eaten up by macrophages, and those macrophages cause lysis around the bone and lead to loosening. And that has been the challenge for last so many years. Most of the knees don't last beyond 20 years. But if we overcome this, these wear, polythene wear and even metal wear, if we can overcome that, then we'll produce a perfect knee. But so far we have been able to lessen it to quite a degree. We have developed very specialized polythenes which have got very special techniques. The polythene wear is very less, but still it is there. cruciates as another new designs coming. These are all examples of different knees. This is a special knee that we do. If you have unicompartmental knee arthritis, just one part of the knee is causing you pain. So instead of changing everything, you change a single joint, a small part of the knee. I find surgery very interesting. I know I'm quite, being a surgeon, I'm not the best judge, but I'll bore you through the surgical steps of the knee surgery quickly. We go through the center, midline incision, we make a hole inside the knee, the femur, and that will give me the axis which what we're talking about, in which axis to cut the rest of the knee. These are the helpful cutting guides that we use, and these cuts are made in special, you can see the 6 cuts that are being made. So if you imagine you're getting a door fitted in your house, or a carpenter working in your house, if you ask him to nicely fit a metal thing on something, they'll do the same. So we do, it's nothing, it's not rocket science, but we almost do the same kind of stuff. So we end up putting this metal on both the ends after making these cuts. Plastic goes in between. We cut the ends of the patella, plastic goes there, and that's the end product. So don't be scared, I'm down to my almost last slide. Now all those steps that I've showed you, they're all taken care of by my computer if you use the navigation system. With the navigation system, all I have to do is I get this picture, and with the jigs they tell me exactly where to cut without having to use with any of those other implants. So it'll guide me where exactly those cuts are to be made. I make the cuts, and we end up with this final product. And once we have done the closure, as our hospital and I especially am very active in what we call as early discharge policy, in which our aim is that the ultimate aim that we have is that we should have the patient come off the bed of the operation theatre and walk home. But unfortunately we have been able to achieve that. That's going to be a few years before we do that, but day surgery has started happening for knee replacement surgery. So the patient comes in the morning fasted, we operate, we give him so much painkillers and local anesthetics around the knee joint that he doesn't feel anything. So the moment they're off the table, we encourage them to start moving and walking. And few young ones who have been trained prior by our physiotherapist, even before the surgery, physiotherapist takes them through the various exercises. They know what to expect exactly after the operation, and there'll be pain. We give them faith that you'll feel pain, but nothing is going to go wrong. That's part of your post-op rehabilitation. You carry on moving. So with that, almost 30% of my patients are discharged in the evening after having major knee surgery, replacement surgery, and almost 15% of my hip patients are discharged. And by the next day, almost 7 out of 10 have gone home. So that we have achieved by combining. We have nurse practitioners who are just dedicated to getting pain relief for the patient. Physiotherapists, we got dedicated wards where we got there's a side room where the patient walks in the first day itself, and the physiotherapists are trained to just push them into doing it. And that's done wonders for us. The patient experience is very good. NHS, so everything is sponsored by government, so it saves money for the government also. And they've really appreciated my effort in being able to achieve that. And I'm hoping that we'll get better than that. Thank you. Yeah.
What about the lubrication aspect after you put the implants? So you need the lubrication because normal knees
Yeah, no, that's very nice. As you must have noted, our main enemy throughout the knee replacement and throughout rehabilitation afterwards is friction. So we are like engineers, and you'll see the metal is so shiny and smooth to decrease lubrication, and the plastic is also kept very smooth. You don't want any kind of friction there. But fortunately, the body, the same synovial fluid that the body had in a normal joint, it makes the same synovial fluid in a replaced joint also. So lubrication comes from that fluid as much as it used to for the other joint. But the only difference is the cartilage that body had given us before had the ability to heal on its own. You cause injury, it will heal. This one doesn't. That's why it fails after some time.
I just want to ask you 2 or 3 things.
Sure.
You said the patient goes home in the evening.
Not everybody. A few.
So are you regularly using drain?
No, I don't put drain in even one single patient.
Don't put it.
No.
And what about the tourniquet?
We use tourniquet during surgery, yes. But if I expect for the knee, I don't even open the tourniquet till I have closed and put a pressure dressing on top of the wound. Some of my colleagues open tourniquet just before they are doing they're putting the cement in, because they want to after they've cemented, they'll open the drain, open the tourniquet, see if there's many major bleeders, cauterise them. But I don't find that gives any advantage.
And one more thing I want to ask, are you doing regularly PS or CR?
No, we like to keep the cruciate.
Cruciate still?
Yes, because I think increasingly the thought process is becoming that cruciates do play a role, especially in the rollback, and I feel that I've done less damage. When you go to revise the knee, a cruciate retaining knee has invariably got less bone cuts. And planning in future, because I do a lot of revision knee surgeries, and if there is a cruciate sacrificing knee, because you have to cut so much bone to have for the plastic, you end up having to put bigger implants in revision surgery, and that's one of the main reasons I don't like to use cruciate substituting ones.
From the slides and from his talk, it was quite clear how much experience and expertise we must have got on this knee replacement. Dr. Sharma, now in India too, we are doing about 8 to 10 replacements every day. We had started navigation procedures about 10 to 15 years ago, and then we gave it up. As Dr. Chandra said, it takes a lot of time when you are planning to do navigation and knee replacement, and now the zigs have become so accurate, and that we finish the knee arthroplasty in just 40 minutes. So as he said, that is it really possible to do navigation on every case, or we keep on doing the accurate zigs?
It's the same thing. I mean, it's your skill base develops if you do it on everything. So it's like, for me, navigation is a jig. I use that as a jig. So it's a tool I use for everything. I do it for easy cases as well as difficult ones. That keeps my skill level high. And initially, you're right, when I started using navigation, I was taking around half an hour more than I would with the jigs. And now, maybe 5-10 minutes, that's all. Because the only thing you will see that it takes longer is you need to get marks of various parts of the bone that needs to be fed to the computer. That takes 5 minutes.